And so for this talk, we'll just be focusing on this first two, the type 1 diabetes and type 2 diabetes. So going first into type 1 diabetes. So we have approximately 5 to 10% of adults who have diabetes have type 1 diabetes. And with type 1 diabetes, we see that it's characterized by the autoimmune destruction of the beta cells of the pancreas. So that's the cells that produce insulin. So this causes there to be an absolute deficiency in insulin. And so people who have type 1 diabetes, about 25% of them, a quarter of them who are newly diagnosed presents with diabetic ketoacidosis, or DKA for short. And this is a life-threatening complication of diabetes where the body does not produce enough insulin to store the blood glucose for energy. And so compared with children, in adults, the loss of the insulin secretory capacity occurs gradually over time with type 1 diabetes, and the body does not. So for people who have like type 1 diabetes, there's usually a longer period where they are exhibiting symptoms before they get diagnosis. So they would have the symptoms of hyperglycemia, which includes polyuria, which is they pee a lot, and polydipsia, where they're very thirsty, and fatigue, for example, before. So they experience this for a longer time before they are diagnosed. So the other thing is that for LADA, or latent autoimmune diabetes in adults, what it is that about 7.5 to 10% of adults in populations that have a high prevalence of type 1 diabetes and with apparent type 2 diabetes have LADA. And it's based on the fact that persons who are diagnosed with LADA are usually older at the time that they are diagnosed, and then they also have circulating antibodies that are directed against the pancreatic beta cells. So we'll be talking more about these, measuring these antibodies later. So in the United States, the prevalence of LADA is not as common among diverse groups for persons of color compared to white persons. And people who have LADA may not require, even though it's a type of type 1, they may not require insulin at the time of their diagnosis, but then over time, maybe months, years, they may progress where they are dependent on insulin. And we'll talk more about, insulin and the management in the subsequent slides. So going into type 2 diabetes, that's the most common type of diabetes in adults. So about 90% of adults in the United States, Canada, and Europe have type 2 diabetes, and it's characterized by hyperglycemia. So usually it's because of progressive loss of insulin secretion, also superimposed on the background of different levels of insulin resistance. So that gives you a relative insulin deficiency. So not an absolute insulin deficiency like with type 1 diabetes, but a relative insulin deficiency. Majority of patients who are diagnosed with type 2 diabetes are asymptomatic at presentation. So they usually don't have symptoms when they're usually diagnosed. However, and this is just because we are used to screening people more often for type 2 diabetes. So people usually find it. So clinicians would usually find hypoglycemia on a routine lab evaluation, and then do further tests to confirm that they indeed have type 2 diabetes. So now patients with type 1 diabetes might have, like I said, might have an absolute need for insulin therapy because of the absolute insulin depletion. Or over time, they might have that, either a presentation over time. But then persons with type 2 diabetes, over time, they lose the beta cell function and would need insulin for glucose management. So whether or not a person needs insulin does not distinguish between it, whether it's type 1 diabetes or type 2 diabetes. So given that there's some overlap between, I guess the symptoms and presentation of type 1 and type 2 diabetes, and as well as the atypical forms of diabetes. Remember, I talked about monogenetic diabetes. We should have a low threshold of testing people for antibodies to be able to determine which one they have, whether it's type 1 or type 2 diabetes. So we measure the autoantibodies when the diagnosis of type 1 or type 2 is uncertain by clinical presentation. So someone comes in and they're thinner, they don't have a good response to the initial therapy things, so lifestyle, diet, exercise, metformin, and sulfonylureas, and we'll talk more about the management later. So you see someone who does not typically have those symptoms. They may have a personal history of autoimmune disorders, or even a family history of autoimmune disorders, and then young adults with diabetes. So those are the people who might clue you in and say, okay, well, maybe let me get some antibody testing. So when that happens, we want to test 2 or more antibodies. So if you're testing 2 antibodies, you want to get you want to look at the islet cell antibodies, or ICA for short, or then glutamic acid decarboxylate 65. So we just call it GAD 65. I have the acronyms at the bottom here. So when I'm talking about that, you can just kind of refer to that. Or then, so you either test with 2 antibodies, or then you do a panel of antibodies. So a panel is 3 or more antibodies. So any of the first 2, as well as other ones over here, which include insulin-associated antibodies, here, back the GAD65, the insulin-associated proteins 2 and then 2 beta, as well as zinc transporter antibodies. And so when you test and 1 or more of the antibodies are present, and especially if 2 or more of these antibodies come out positive or are present, then you presume the person to have type 1 diabetes, and then you treat with insulin replacement therapy, as people who have these antibodies will not do well on diet or lifestyle interventions, as well as oral therapy. So one thing that you also want to note is that of course, measuring more than 1 will increase the likelihood of having a positive, but also depending on which part of the world you are in, you also want to think about cost. So of course, measuring more is more costly. One thing to also note is that if the person has been getting insulin for or insulin replacement therapy for 2 or more weeks, then you do not want to test the insulin antibodies, because giving insulin like that will generate antibodies to insulin. So here we have a table that will help us look at the differences between the 3 types of diabetes. So some areas to point out. So you will find with type 1 diabetes, you will find that they do, compared to the others, they do have antibodies, so only with type 1 diabetes. Also, the risk of diabetic ketoacidosis, like I said before, is higher in persons with type 1 diabetes compared to the other forms of diabetes. With type 2 diabetes here, we have like insulin sensitivity is decreased, but they're usually normal with some caveats in the others. And then the other thing that you want to also look at is family history of diabetes. So family history, you're more likely to have it in type 2 or you're more likely to have a positive family history in persons with type 2 or multi-generational diabetes. Sorry, or monogenetic diabetes, sorry. So the question comes, well, how do we diagnose diabetes? So for persons who present with symptoms of high blood sugar or hypoglycemia, we can easily make the decision, we can make it if they present with the classic symptoms of hypoglycemia. And so I'm not sure whether you've heard of, we call it a 3 poly. So I mentioned it a little bit before. So polydipsia, which is excessive thirst, polyuria, which is frequent urination, and then polyphagia, which is, hunger, eating a lot. But then they also may have weight loss and then some blurry vision. So those are some presentations of, so classic presentations of hypoglycemia. Polyphagia is not always present, but you have your polyuria, polydipsia, weight loss, and then blurry vision are much more common. So you're looking at the diagnosis is made with classic symptoms of hypoglycemia, but then also looking at a random blood glucose. So the random blood glucose level is greater than, depending on which part of the world you are on, you can say 11.1 millimoles per liter, greater than 11.1 millimoles per liter. Something to note is that, more patients with type 1 diabetes, a presentation would be symptomatic at blood glucose levels of 11.1 millimoles or greater, and some patients with type 2 diabetes will have symptoms with that. So what about if they don't have symptoms? So when they don't have symptoms but you're trying to make the diagnosis of diabetes, usually with type 2 diabetes more often than type 1 diabetes, you can diagnosis with the following criteria. So they should have fasting plasma glucose levels of 7 millimoles per liter or higher. So fasting is talking about not having eaten in the prior 8 hours. Also, if they have a 75-gram oral glucose tolerance test with the blood glucose levels of 11.1 millimoles or higher, and A1C levels of 6.5% or higher. One thing to note is that we don't necessarily use oral glucose tolerance tests as often in the regular public. Is more common with during pregnancy, and this is just because doing a 2-hour oral glucose tolerance test is quite inconvenient. So what is the criteria? So to make a diagnosis of diabetes, you need to have the following tests at least. So an A1C, a fasting plasma glucose, or oral glucose tolerance test. So according to the American Diabetes Association, so you need, you need the following. So either one of the following. So you need either an A1C level of 6.5 or higher, fasting plasma glucose of 7 moles or higher, millimoles per or higher. And we talked about the 2-hour oral glucose tolerance test with a 75-gram load of 11.1 millimoles or higher. Or then in a person who has the classic symptoms of diabetes, of hyperglycemia, sorry, a random plasma glucose of 11.1 millimoles per liter. So these are needed to confirm a diagnosis of diabetes. So going back to type 1 diabetes. So now that you have a diagnosis of type 1 diabetes, or you've given someone a diagnosis, or someone has a diagnosis, how do you manage it? So the two areas of focus that you want to or the two areas that you want to focus on is insulin replacement, and then the coordination of caloric intake and physical activity to prevent or minimize the amount of time that this person spends in hypoglycemia, so less than 3 millimoles per liter, or hyperglycemia, greater than 13.9 millimoles per liter. And so the goal of providing insulin therapy is to create essentially a physiological profile of insulin. So you either give, so you want to give a basal insulin. So usually this is done in using intermediate or long-acting insulin, and that's giving either daily or twice a day, or a rapid-acting insulin preparation continuously via an insulin pump, for example. And then you frequently monitor your glucose levels. The other one is to also give boluses, so prandial of a rapid or short-acting insulin with meals. So that's known as the basal bolus therapy. So then regarding targets, glycemic targets, you do want to look at two things. So you want your hemoglobin A1C and the range for healthy, young, and middle-aged adults in general to be less than 7%. We see that a lot of persons who have type 1 diabetes do not usually achieve this goal, but the highest that we usually see are in adolescents and young adults. So you want your glycated hemoglobin or A1C to be less than 7%, but you also want your blood glucose levels to be between 3.9 and 10 millimole per liter. All right, so here we have a summary of the different types of insulin that are used for basal bolus administration. This chart would also, especially with the basal one, would be helpful with type 2 diabetes, but I'm getting ahead of myself. So this is a summary of the insulins that we use for basal bolus administration. So you have the rapid ones that are used at meal times or in an insulin pump, or then the longer acting ones that are used as basal insulin and are giving either once or twice a day. So this one is a shorter acting one, it'll be giving more than once a day. Your glargine, your detamir, the glucagon ones are going to be given, typically once a day. So moving on to the management of persons with type 2 diabetes this time, the focus should be on education, evaluating them for micro and macro vascular complications, and as well as minimizing the incidence of cardiovascular and other long-term risk factors, striving to achieve near normal glycemia, avoiding medications that can worsen the abnormalities of insulin or lipid metabolism. So while we're doing all of this, we need to be cognizant of individual factors, right? And adapt a target or focus. So things that to consider is, someone's age. What is their life expectancy? What other comorbidities do they have? And then when you're looking at actual medication, so the medication or treatments to improve glycemic management typically work in a number of different ways. So they either increase the availability of insulin, and you can do that either by direct insulin administration or through medications that promote insulin secretion, and then improving insulin sensitivity, delaying the absorption, the delivery and absorption of carbohydrates in the GI tract, also increasing the urinary excretion of glucose, or then, medications that combine, one or more of these things. So since the goal is to have your blood glucose levels more within a lower target range. So initially, you want to encourage lifestyle changes that decrease physical activity and decrease weight. So this can, so lifestyle activity, so we talk about, eating healthier, exercising frequently. This can drop an A1C level by 1 to 2 points. And also you have metformin. So metformin is used to increase insulin sensitivity, and that can decrease your A1C also by 1 to 2 points. So if, I know there's a lot on the slide, but bear with me here. So if your initial therapy, which is the metformin and the lifestyle modifications, does not get the patient to the target range, then you want to do some of these additional therapies in here. So for type 2 persons with type 2 diabetes, that means that then you would either put them on insulin. And so you might start with basal insulin. So basal insulin, using intermediate or long-acting insulin, can further drop the A1C up to 3.5 points, or percentage points. And then depending on whether or not how they do in their progression, you may decide to include prandial, so mealtime coverage, but that's much later after trying some of these other ones. So you also have sulfonylureas, which essentially stimulates help the body stimulates insulin secretion from the pancreatic beta cells. You have GLP-1 receptor agonists. So these are usually injections. So they help to slow down digestion, increase insulin release, and prevent the release of glycogen, so the stored glucose in the body. And then you have the short form, we call them TZD. So these would also increase insulin sensitivity. They act on different, I guess I would say organs or different parts of the body, like muscle, fat, the liver, to increase the usage of glucose already in the body, and decrease the production of glucose. So for example, like glycogen. So then you also have the glinides. So you can take these up to 3 times a day before meals, and it also helps the body to increase insulin production. It stimulates the beta cells, and it's very similar to the sulfonylureas. We have SGL2 inhibitors, and here they essentially help with urinary excretion of glucose. So things that you need to watch out for are, candidiasis, urinary tract infection, things like that. So they decrease the blood glucose without stimulating insulin release. Just essentially tell the kidneys to prevent reabsorption of the glucose. And then you have DPP-4 inhibitors. These ones decrease gluconeogenesis, and then they also increase insulin production by the liver. You have alpha glucosidase inhibitors, and so this delays the digestion of your complex carbohydrates, and glucose absorption in the small intestines. So then you have the pramlintide, and these essentially slow the movement of food through the stomach so that it prevents that spike in blood sugars. And then I'm going to just very briefly describe some of the work that I have been doing. And so a lot of my work involves, working with immigrants of African descent. So in my previous work, we examined the prevalence of diabetes and other cardiometabolic risk factors among African immigrants in the Baltimore, Washington area in the United States. And what we observed was that there was a high prevalence of diabetes and hypertension. And so to address this issue, we essentially sought the African immigrant communities input. We used focus groups. We developed a community-based, culturally tailored adaptation of the National Diabetes Prevention Program. And I know, our next speaker is going to be also doing some more discussion about things like this, but we called it the Afro-DPP program. And so it was a year-long cluster randomized control trial using a non-equivalent control design. Initially was intended to be in person, but then due to the pandemic, we had to switch it to a virtual format. So it involves remote monitoring of blood pressure and body composition using Bluetooth blood pressure devices and Bluetooth scales. And the participants are now halfway through the intervention. Like I said, the first group was, because of the non-equivalent design, the first group essentially were giving 6 months of a lifestyle intervention with a lifestyle coach, as well as remote monitoring of their blood pressure and body composition, their weight, and etc. After which, then the delayed intervention just recently started their part of the intervention. So it involves 5 study visits with measurements and a total of 31 life coach sessions. We're using REDCap for to obtain data through surveys. We're also doing remote monitoring of their blood pressures and their weights and other body composition. And the last one, because it was born in the community, I just wanted to share some ideas that we used during this intervention to help the participants virtually and to encourage their morale. So we did monthly newsletters and report cards showing their progress. Gave them completion certificates, cookbooks with the recommended recipes, and then study paraphernalia based on, attendance levels and things like that. Almost like maybe for every, if you do 3 in a row, you get, like a measuring cup or something like that. So, for these have been received very positively, and we're looking forward to determining the outcome of the intervention. And I will go ahead and stop here. Just thank you so much. Stop sharing.
Thank you very much for your valuable sharing, Dr. Ruth Almar. Before we move to our second speaker, I would like to make a short summary of Dr. Ruth Almar's presentation. She mentioned about the updated clinical presentations and diagnosis of several types of diabetes mellitus. Also, she focused on the clinical management like medication in the patients living diabetes mellitus. And she also showed about her research that is very interesting. All right, we're gonna move to our second speaker, Dr. Satima, gonna talk about nursing care aligned with the current trends of diabetes care. Dr. Satima, please.
Thank you. You can see my slide. And
yes.
Okay, thank you. And can you hear me clearly?
Yes, very good.
Thank you. Good morning, guest speaker. Dr. Ruth Alma, and good morning, our audience from Western time, and good evening, our audience from the Indochina time. I'm Dr. Sathima Suratham from Faculty of Nursing, Maidon University. Let's learn from the first part from Dr. Ruth Alma. That is the variable knowledge for the healthcare provider who work with the diabetes patient, as I am a diabetes educator. That your presentation help me like a very short in-depth update, in-depth knowledge of the diabetes in terms of the medical part or clinical part. Next, I move the current trend in diabetes care in terms of the nursing care or non-medical care of all of you to know which method that can help or improve the diabetes care quality for the patient. Today, my outline I will present in three topics. The first one, I will start with the concept of diabetes self-management education and support. Next, show the role of certified diabetes educator for diabetes patients. And finally, present the current research that I just was published and the ongoing project for improved diabetes care quality. I would like to show this slide first to remind all of you that you are a healthcare provider, work with diabetes patient. One patient, they need more information or more education for accept responsibility for their self-management. And also, they need many support from many disciplinary team. It looks like quite complex. How you manage help the patient can achieve the goal to have a good glycemic control or have a good health status. I will show you later. I think that many healthcare providers or many settings are faced with this problem. From the perspective of healthcare provider, I think that we need more education for the patient. But sometimes, and our patient feel like overwhelmed or bored when they receive many education or knowledge at the one time. And my question that, what are the obstacles to diabetes education? From my experience, as from the study in 2019 on title the obstacle to diabetes self-management education and support from healthcare professional perspective. It's shown that high workload, unclear diabetes role, and a lack of diabetes skill to support patients with behavioral change are the primary obstacles to diabetes education. Thus, the concept of DSM-DES or diabetes self-management education and support that's used for a long time and still significant for the treatment of the patient with diabetes. In 2022, from diabetes care, it's shown that the DSM-ES is a critical element of care for all patients with diabetes. This concept have a purpose to give the knowledge, the skill, and confidence to accept responsibility for their self-management. including collaborative with their healthcare team, making informed decision, solving problem, developing personal goal and action plan, and also coping with the life stress. Finally, they still said that DSMES is a vital component of the full treatment for diabetes. Why this concept is a key component of the treatment of diabetes? Because this concept is a paradigm shift from the content-driven to outcome-driven. In the past, we provide the education to the patient mostly based on content-driven. It makes patients feel like but they cannot apply the knowledge fit into the real life and cannot have a good self-management. The DSMES is outcome driven. It makes patients feel desire to change their behavior for a long time and have a good self-management of diabetes. From Diabetes Care in 2015, revealed that the benefit associated with DSMES, it can improve the glycemic control, especially hemoglobin A1C as much as 1%. As you see from the presentation of Dr. Ruth Almar, is quite equal and medicine to reduce the hemoglobin A1C. And it can reduce the onset of diabetes complication. Also can reduce hospital admission and readmission. Furthermore, it can improve quality of life and lifestyle behavior of the patient. The principle of DSMES, including a principle, is patients have a desire to learn, and learner center or patient center. We try to use a concept, develop the plan, individual plan fit into the real life for each patient, and set the priority from simple to complex step of the education. Finally, the continuing education or evaluation is also very significant, because if we provide many education for patients to improve their self-management, if we don't do the evaluation, sometimes the patient have another problem that related to their self-management, is make patient cannot reach the goal to have a good glycemic control and have some complication. The process of DSMES including 4 process. The first one, assessment. Second one, planning. The third is implementation, and lastly is evaluation. The step of assessment is very significant. In the past, we don't start the education by put many knowledge on assess many background of their self-management. The concept of the DSMES on the process, we need to do the first step completely, because it's very useful and significant when we set the goal or develop individual plan for the patient. Because sometimes from my experience, I learned that many patients did not lack the knowledge of their self-management, but sometimes they have other problems For example, family support or financial status, but they don't correct this problem and they don't like to change their behavior too. That the assessment that related to their self-management are very significant. For example, medical history, cultural influence, health belief, our background of the knowledge. Next, the planning. As I said before, the planning, we have to set the goal, both short-term and long-term goal. If we set only the long-term goal we need all patients can achieve a good glycemic control, right? And don't have any complication and have a good quality of life. But it uses a long time to achieve this goal. We should to set the short-term goal too. It help patients easily to can achieve the goal and feel better when they can achieve the goal step by step. And the individual plan, that's as Dr. Ruth Alma said, many all patients they need individualized treatment or knowledge or education is not fit to all patients because they come from different backgrounds. Lastly, the priority setting is very important. If you see from my first slide, many knowledge or many education that we need to provide to the patient, but we can do in the first time or in the one time, because the first time there's mostly patient feel like confused or reject to accept their illness. We try to make counseling and provide only the significant survival skill to them. For example, if we found from the first step of assessment, they have a big problem in terms of cannot do insulin injection correctly. We try the first time that we see the patient, we have to teach and demonstration how to do the insulin injection and may add some part of the carb counting because that is related to the glycemic control. We should put another part of the knowledge that can help the patient easily to accept responsibility for their self-management. Let's move to the next step of the DSMES, the implementation. I think that is not easily for our healthcare provider who work with the patient because we have a different background of the education of the patient with diabetes, right? We have to do our transfer the many knowledge to the patient, understand easily. The tool or the media that very significant to help them to easily understand. For example, interactive tool, food model, or the real equipment for the insulin injection technique, something like that. And sometimes we provide the leaflet for the patient to revise the knowledge when they go back to the home. Lastly, the step of evaluation. For each patient, they need the follow-up evaluation time that's different, depend on the complex of the illness. The first diagnosis mostly follow up or evaluate the 3 parts, including behavioral part, psychosocial part, and medical part, away every 1 month or 3 months. If they can accept responsibility for their self-management. Sometimes we do the evaluation every 1 year to recheck the understanding too, and also like recheck the problem, because sometimes we already assess at the first time we found another problem that affect their self-management, but after that for 6 months or 1 year they have a new problem that related to their self-management, that we have to help them to solve this problem, which improve their diabetes care. The first part that I share to all of you in terms of the concept of DSMES. The next, I would like to move to the educator. The educator will help the physician is very significant too. Who is educator? I just remind that the educator is a person who teach, inform, and inspire others. Could be nurse, dietitian, physician, or other relevant person. For diabetes educator, that is more specific than educator, who is a healthcare professional, specialized and certified to teach people with diabetes how to manage their condition or their illness. Moreover, possessed in-depth knowledge of diabetes and skill such as communication and counseling. As I said previously, some patients, they already have the knowledge of the self-management of diabetes, but why they cannot change their behavior to achieve the goal for good glycemic control? Because they have some problem that they need only like the counseling to empowerment or motivation to support them to achieve the goal. That is why the skill of communication and counseling are significant. So in Thailand, we have 2 ways to become a certified diabetes educator. The first way is part the certification examination for diabetes educator of Thai Association of Diabetes Educator. The second way, as I complete from this program, Certified Diabetes Educator Program from Faculty of Medicine, Sirat Hospital. This program is a comprehensive program, provide both update, in-depth knowledge for diabetes and the significant skill for helping the patient to have a good self-management. All of you are invited to enroll to this program. If you want me to help to enroll to this program, can contact to me directly. This program provides to the healthcare provider who earn advanced degree in medical field, such as physician, nursing, pharmacology, nutrition, and health education, and have the experience or practice with diabetes at least 2 years. After we pass this program and as a CDE, we have to keep up with continuing education and practice to renew the certification every year. It needs 50 hours per year to renew the certification. The responsibility of CDE is the education of the patient and their family by providing DSMES with an individual plan and also serve as a resource to assist in the individual and other professionals. Okay, I already finished the first part and the second part of my presentation. The next part that I would like to show all of you and to share with all of you in terms of the current research that I just was published in the journal and the ongoing project to improve the diabetes care. The first one, this paper just published in 2021. As I am a CDE and I use the technique of DSMS to support the patient since they were first diagnosed until about 1 year, followed by the step of the DSMES and use all the principle of the DSMES. It can improve their glycemic control and quality of life. That this concept is confirmed that is an important strategy for taking care of the diabetes patient because it can help the patient have a good glycemic control and have a good quality of life. Right now, this patient, they can line up. There is an adolescent type 1 diabetes. They can go to school and have a joy all activity with the friend normally and have a good quality of life. The next project, this is ongoing project. I would like to share all of you that I learned from the first paper that I showed you previously. And I learned from the COVID-19 pandemic. When we do implementation for the patient, we face some problem, especially during COVID-19 pandemic. We limit the patient to the hospital because we protect the spread of the COVID-19. That is disrupt the continuing education for the patient and disrupt the evaluation. Some patients it might line a complication and lot of the follow-up. The ongoing project that I developed, the telehealth, is like an application how the patient can have a continuing education from the healthcare provider to improve their self-management and quality of life. These projects will conduct pilot study in type adolescent and early adult. In type 2 diabetes will visit the outpatient clinic. And after that, I will expand to the more setting, both tertiary and primary care. That is all my presentation for today. Thank you for your attention. If you have any question, you can leave the message or ask me later. Thank you.
Thank you very much, Dr. Satima, for your great presentation. All right, before we go to the Q&A session, let me take a quick summary of her presentation. Dr. Satima focused on diabetes self-management education and support, or DSMES, and she also pointed out the roles of certified diabetes educator. I think this is very important for improving diabetes care. And her also present her research project in the people living with type 1 and type 2 diabetes that I think we may get more idea from her research project. All right, we move to the Q&A session. So without further ado, I'm gonna begin with the first question. The first question is for both of the speakers. Could you please share your experience in diabetes care during COVID-19 pandemic? Shall we begin with Dr. Ruth Alma first and followed by Dr. Satima? Dr. Ruth Alma, please.
Yeah, so thank you very much. So during for the most part of the intensive part of the diabetes, so of the COVID pandemic, diabetes, well, we were seeing a lot more diabetes, in people. So especially if they were diagnosed with diabetes and if they were diagnosed with COVID, sorry. So you would see abnormal blood glucose in people who didn't have it. And especially if they were not, admitted into the hospital, what I did was I was essentially an inpatient diabetes management consultant. And so we're seeing much more, higher levels of insulin need in people. I would say that this, the COVID pandemic, really did show us, I guess, move a lot of our things into the virtual mode in terms of, figuring out how to monitor people virtually. A lot of people got the use of pumps, even in insulin pumps, even in persons who had type 2 diabetes, especially a closed loop pump was something that more and more people were considering as during the pandemic as opposed to before the pandemic. And just to explain, a closed loop insulin pump essentially is you have your insulin pump, which is delivering your short acting or your rapid acting insulin continuously, and then you can always program the pump with it, but you're also having a continuous glucose monitor. So the pump senses the continuous glucose, your insulin levels, and then delivers your insulin, the pump senses your glucose levels through the continuous glucose monitor and then delivers it. So it's almost kind of like continuous without people having to do a lot more things. And so that was that was kind of nice for people to get on there, and more of the manufacturers also started doing those things. So I would say, especially for mine, was more in the inpatient, maybe transitioning setting. That's what I saw. And I'm curious to see what Dr. Suratham's experience also what is. So I'm looking forward to your reply.
Right. Thank you very much, Dr. Ruth Almar, that you have like a very good care of the people with diabetes mellitus. All right, move to Dr. Satima. You can share your experience, please.
Yeah, from my experience in the last year, as I am a CDE, we conduct a telephone follow-up to evaluate the glycemic control or the self-management of the patient, because we found that, like that Dr. Ruth Alma said, many patients have a high blood sugar, and some patients, they don't like that complete or receive the medication or full medication because they lost follow-up or they afraid of the COVID-19 infection, that they don't go to the hospital, but in the real life, they can go to the hospital to receive the medication continually. But they said that they are afraid of the infection of the COVID-19. Thus, we do the telephone follow-up to suggest them to follow up or see the doctor via telemedicine to receive the medication or insulin continually, because the medication is very important to control their blood sugar during the COVID-19 pandemic. And also we try through like the evaluation, the understanding of their self management, because we found that the effect from the COVID-19 pandemic that limit the patient go out to like do physical activity or exercise, that it affect or increase their blood sugar too, because we know that the exercise is the one method of the reduce the glycemic control, right? That the COVID-19 affect their activity. They don't have a chance to do exercise at the same as previously. Sometimes we suggest them via telephone to adapt or change their behavior into the new way that fit into the real life, that can help them to have more physical activity or more exercise that is better for them to reduce or control blood sugar. Mostly we do via telephone and provide the telemedicine for the patient.
Thank you very much, Dr. Satima, for sharing your experiences. And I'll move to our second question for Dr. Ruth Almar. The question is, from your experience, what are the major problems encountered in the management and control of diabetes in the US? Dr. Ruth Almar, please.
So thank you for that question. So there's, I guess a healthcare system is a lot different from other people's, I guess, settings, right? And so one thing that has been very, some things that have been just challenging is maybe like the price of insulin. For example, I think most of our issues might be relating to, I guess, access and then, expenses related to cost. So, like a lot of people might have, a certain amount that they have to pay out of pocket per month. And so maybe they are only allowed maybe one insulin pen or one insulin vial a month, but then their blood, but then whatever their needs are maybe greater than that. And so you're having outpatient costs. So maybe almost like, like $30 or something like that for a vial or for a pen of insulin, depending. So that's one of the issues. The other issues is, trying to figure out, like the lifestyle management, what kind of works for people. So of course, we talk about, healthier eating, but not everybody may have the opportunity to do that. Unfortunately, unhealthier foods are cheaper. And so people, might have, especially depending on if they're on the lower income aspect of things, might have issues with, food security, might have to be skipping meals a day, eating unhealthy stuff, which is higher in carbohydrates, and things like that. So I would, and other people just cannot get in to see their regular healthcare providers. A lot of times the emergency, you cannot be turned away from the emergency room. So the emergency room becomes like a primary care place where people have to go, because then whether or not they can pay for the services, they would be provided services. So that can drive up healthcare costs, but then it's also a means to an end for a lot of people. So I'll just end here because I could talk for a long time about this issue. Yeah.
Thank you very much. I think this challenges is still the challenge in the US and also in Asia. And I have a question for Dr. Satima that I use the same question that with Dr. Ruth Almar. From your experience, what are the major problems or the challenges that you take care of the patient with diabetes mellitus in Thailand? Dr. Satima, please.
Thank you. The challenges for me, as I am a CDE that providing care for the patient, as I mentioned, the first step when we see provide the education to the patient, the step of assessment, because from my experience, I learned that the different in each patient, they have different background. Some patient we can like assess easily to know the background that related to their self-management. But some patient that is quite difficult to find the problem that's related to their self-management of their diabetes. Because if we provide only the knowledge is not the challenges, but that, as I said, that from my presentation, the DSMES that's focused on the outcome driven, we have to background of the patient that related to their self-management, because many parts of the background that's significant, that help to improve their self-management if we know the correct the correct problem of the patient. That is challenges for me as I am an educator. Some patients we use take a long time to do assessment, that to know what is the problem, not only lack of the knowledge, because this information from the step of assessment that useful when we do develop individual plan for the patient.
Thank you very much, Dr. Satima. All right, as we are running out of time, this would be the last question for both of the speakers. Do you have any take-home messages for our audience today? Shall we begin with Dr. Ruth Alma, please?
In terms of, I guess, take-home messages is just like, diabetes education, and that's probably Dr. Satima's, forte is, like educating people about how to, I guess, primordial prevention or primary prevention. You want to try to prevent things before you have to go into managing it. And so, just spending that extra time to, either, like eat healthier, live healthier, or then if that's, because you have the genetic components of it, just trying to, I feel like a lot of people might be in denial about how much risk they have. So just kind of just saying that, like nobody's infallible, but just doing the best that you can and under the circumstances can help, like prevent complications. Because obviously, if it's genetic, if you're already in it, what you want to do is to lessen the brunt of diabetes, avoid complications, and live a healthier, happier life also.
Yeah.
Oh, thank you very much, Dr. Ruth Alma. I think the complication from diabetes mellitus is very important that we have to prevent, right? All right, move to Dr. Satima. Can you give us the take-home messages for our audience? Dr. Satima, please.
Thank you. Firstly, agree with Dr. Ruth Alma. The prevention of the complication and improve quality of life of the patient, that very significant that we need, right? And for my take-home message, that I would like our audience to update the current knowledge and the skill for the diabetes care, like you enroll or participate in this webinar, because all of the knowledge that you learn from today, that is the in-depth current in-depth knowledge and significant skill that can help or improve the patient, improve the quality of care of the diabetes patient. That I invite all of you to update the knowledge and skill. Thank you.
Hey, thank you very much, both speakers. We have now come to the end of this webinar, and we had so much fun and full of knowledge about diabetes care today. On behalf of the MU JSU NCD Research Collaborative Center, I would like to thank our guest speakers from Johns Hopkins School of Nursing and Faculty of Nursing, Mahidol University, for their insightful presentation. All right, before we leave today, please evaluate our webinar by using the link in the chat box. And our next webinar will be held in October, and the topic will be announced very soon on the website, Facebook, and Instagram. Please stay tuned. All right, also I have the announcements from the MUJSU NCD Research Collaborative Center that you have already seen on the screen. And we have the short course training program of fundamental for implementing a hypertension program in resource constrained settings. And this course is for international and Thai healthcare providers like nurses or physicians, and graduate students are also welcome. And the course will start on September 12th to September 22nd, 2022. After finishing this course, the participants will receive like a certificate, and also for Thai nurses, you can earn the CNU credits also. If you are interested and need more information, you can visit our website or scan the QR code to get more information about our course. All right, finally, thank you very much our participants for joining us today, and see you in the next webinar. Have a good day and night. Thank you very much. Bye.
Thank you very much.
Bye.
Thank you.